apparent for many years, too blindingly apparent. And then based on our visions that we put forward in the manifesto, we came up with, and the visions, which are recommendations, we came up with indicators for which to score the past decades of HIV efficacy trials. And we're going to present today for the first time our global debut of the data, of the results of how well the field, the HIV research field, has done as far as trans inclusivity in its research. Next slide, please. So several years ago, while we were looking at the inadequacy of trans representation in HIV research, and that's both treatment and prevention, we said we finally need to come up with this manifesto, with this agenda. So AVAC, being sort of the working in the HIV prevention space, we needed to form a really tight team of trans representatives. So here is listed the awesome authors of the manifesto. Just really quickly, Max Appenroth from Germany, Ricky Kokosatu from Cape Town, JD from Brooklyn, Ima Mugo from Cape Town, Rory, the artist whose work you'll see throughout this presentation, and myself. And I hope that some of you are on the webinar, and you can give us a shout out and weigh in today. And then we formed a trans advisory group where 10 of the 11 members were actually trans or gender nonconforming, and many of them had been in the HIV activists for many years, and also several of them themselves were researchers. And I want to give a big shout out to Craig Hendricks, who was the 11th member, non-trans, who is a researcher at Johns Hopkins, who was also very helpful. So very quickly, our methodology for the actual manifesto was just a literature review. We surveyed lots of trans people around the globe. We did interviews with them and with researchers as well, and trans researchers. We went to workshops and we came up with a manifesto. We did external reviews and fact checks. Next slide, please. So why the manifesto? I'm going to hand this over to my lovely co-conspirator, Leanne Vanderberg.
Thank you so much. Thank you so much for that, Cindra. Thank you, Jim. And, everybody who's joining from around the globe. It's such a privilege to be speaking to all of you. So why is it important to have a manifesto like that? Well, first and foremost, we exist. We exist in all of our glory. And we are no longer going to be pushed to the margins when it comes to HIV prevention research, both in prevention and treatment. Also because we know that the trans community face a disproportionate burden of HIV. A recent meta-analysis found a 20% pooled prevalence of HIV globally among transgender women, and that transgender women are 66 times at higher risk of infection for HIV. And for transgender men, 2.6% HIV global prevalence and 7 times at high risk of HIV infection. And as it goes, we have no data for non-binary folks. Also, surveillance data is very limited, especially Africa, Eastern Europe, as well as Central Asia, and that we have unique needs in the HIV response, as will be unpacked later throughout this presentation, and that as a community, we are not monolithic. Please advance the slides for me. So continued on the reasons why we need this manifesto, we know that from the lack of data, we can deduce that trans people have historically been overlooked or avoided in HIV research. We've heard, especially in the Global South, many scientists saying that, the inclusion of trans people tend to be complicated in research. And, that's been one of the reasons why we've been there's been a lot of gatekeeping and, involving transgender communities within research. In particular, there's been no HIV endpoint trials with primarily trans populations. Transgender women have typically been subsumed as subgroups in randomized controlled trials with cisgender MSM, and trans men have been excluded in many research efforts. And of course, we have very limited implementation studies. The increasing incidence, and there's an increasing incidence in our community, and we are less likely to get tested, less likely to adhere to PrEP, and less likely to maintain viral load suppression. So as part of our manifesto, we've looked at the data, we've looked at what is out there, and from our review of the data, we came up with three, call them buckets, if you will, or three thematic areas that emanated from the data. And I will be presenting these three thematic areas to you this evening. Thank you. The first being, that if we're talking a manifesto, it means there are some political demands that we are making. Without that, we cannot truly call it a manifesto. And so the first of the thematic areas, the three thematic areas, is focused on the lived experiences of trans people. We want to have an identification of the key drivers of incidence across countries and regions. Those of you who have a big focus on HIV data may know that while the research is showing fairly high incidence and prevalence rates for transgender communities, we do have some regional differences or, a country level differences that we have in terms of the exact data. Also, we wish to undertake a global analysis of data gaps in trans research and health programs to address structural barriers to research engagement and health programs to find out why folks are not forthcoming and participating in studies. To fully consider the range of participants along the gender spectrum in clinical and implementation research, to track epidemiological data on HIV incidence and prevalence that accurately reflect the large and growing HIV acquisition rates of trans and gender populations. I did say in the opening of my slides that we are not one homogeneous community. And I think if we are going to do HIV interventions that are appropriate to our communities, it's really important to understand the difference or the diversity of us as a global community. And also that we should embrace the UN AIDS top line targets for 2025, aiming for less than 10% of countries with punitive legal and policy environments that will deny and limit our uptake of these services. And this is about, we know that global programming is coming to our countries, but those are all in vain if we don't feel confident or safe enough for us to be able to participate and access these services. Next slide, please. I want to make the point here that what we're presenting on each of the points under the thematic areas are just some of the examples and some of the issues that had come out of the data, and that it's not comprehensive, and that we've selected these as being important points to talk about under each of the thematic areas. So the second thematic area that we want to talk about is the role of gender affirming hormone therapy and healthcare. and that we should explore how gender-affirming hormone therapy might affect HIV sustainability is a really big thing for the trans community globally. To further study the drug-drug interaction between hormone therapies and antiretroviral therapy, to ensure that all new PrEP compounds in development are undergoing sufficient drug-drug interaction studies with feminizing as well as hormonizing or masculinizing hormones, and then studies that specifically address the urgent efficacy and safety questions of on-demand oral PrEP for trans and gender diverse persons on gender-affirming hormone therapy. And then lastly, integrating gender-affirming care across the HIV care and prevention continuum, as well as the research settings. Next slide, please. The final thematic area is looking at HIV prevention research and data that can disaggregate, if we can disaggregate the data by gender identity to provide inclusion criteria for trans people across the gender spectrum in clinical trials and report how gender is defined by the study protocol. I was so excited when Jim was showing us earlier a conference on decolonizing global public health, because I think the very first thing that that Northern and Western countries get wrong is about how transgender people are identified by religious or ethnic terms that describe gender identity. There are many in my context in South Africa, and I know there are many in other settings around the globe, such as India, Thailand, and so on. Also, under this particular point, to adhere to the NIH HIV language guide and report inadequate trans representation in enrollment data as part of the limitation of the research project as a whole. To explicitly, we call for the explicit inclusion of trans men and other assigned female at birth trans people in the eligibility criteria of all clinical trials. And we've seen with many of these trials that when we talk the inclusion of trans people, we really mean trans women. And so our manifesto is making that very specific political stand that there needs to be very intentional and explicit inclusion of trans men and other assigned female at birth persons within the eligibility criteria of all HIV clinical trials. Then the research site should be populated by employees who represent the trans community, and that it should, competently offer trauma-informed care. And I want to really make this point around the inclusion of trans community. We are at a stage of the epidemic where trans people are no longer, entertained by the idea of being data collectors only in studies. And the point that being trans and being an advocate is not mutually exclusive from being a scientist and a researcher. There are many of us who navigate these dual roles in our everyday personal and professional lives. So there's no longer an excuse for the research, international research community to say that trans people don't have the capacity, to navigate both our identities as trans people as well as being scientists and researchers. Thank you, colleagues. I'll stop there and I'll hand back to my colleague, Cindra Feuer.
Thank you, Leanne. So thanks, Leanne. As Leanne said, she was selecting the visions and the recommendations. There are others, and I want to just call your attention to, please, if you haven't actually seen the manifesto yet, there's over 24 visions that we want to see operationalized going forward into the future about and how to actually realize trans inclusivity in our research endeavors. There's also, and I know a lot of questions will come up, and on this webinar probably, and there's a lot of still unknowns and big questions about drug-drug interactions with PrEP and gender-affirming hormones. And there is a chart in there. It was published in 2021, but there is a chart that lists some of the key pharmacokinetic studies that really give some data about the drug-drug interactions between feminizing and masculizing hormones and different PrEP ARVs. So that's worth checking out as well. And there's additional references in the manifesto, and of course there's more gorgeous art. So please do take a look at it if you haven't already. And then as far as, again, operationalizing and really breathing life into this as an advocacy tool, what we've been doing, myself, Brian, and Leanne, and some others have been really taking this on the road, virtually on the road, not literally, and having dialogues with researchers, funders, pharma, communities to help really sort of support the visions in here to really get them enacted, and to support researchers who, there are a lot of researcher advocates and activists and allies, as well as trans and gender nonconforming, as we said. So this is just another way to support them and to alert communities that you could get involved in helping to advocate for trans inclusivity. And then we also at AVAC, we have a transgender ROAR program, which ROAR stands for Representation, Outreach, Advocacy, and Research, Outreach, Advocacy, and Representation. And we support advocates in their countries, mostly in Southern and Eastern Africa, to actually do trans inclusivity and gender justice activism on the ground in their countries, to really advocate for gender diversity on a national level. And as I had mentioned before, from the manifesto, we have taken these visions and we are debuting today for the first time our scorecard data that shows how well these visions have been enacted historically in the efficacy studies, and how you will see we are sort of at a pivotal turning point, and how to take it into the future. So we will be releasing a template based on these indicators, so that you all can take these indicators into the future and work with researchers and community to realize some of these visions as well. And we're looking to publish these findings as well in 2023. So these are preliminary findings, and we're really happy to be debuting them today. And I think I'm before I hand it over to Brian, we're going to stop here before we go into the scorecard findings, before we go into the ratings of the trials, and see if there's any questions on anything manifesto that we've gone over. I haven't been looking at the chat. So Jim, are there any questions that have come up? Are there any?
I've been dominating the chat, dropping in lots of juicy links for everybody. But I'm going to take this moment again to encourage people to share their questions or thoughts in the chat. Or right now, you can raise your hand and say or speak your question or comment verbally on camera. So we'll give you a moment. Oh, yeah. I see somebody. Ernest, why don't you go ahead and unmute yourself and tell us what you have to say?
So, good morning, good afternoon. My question is not specifically to the presenters, but just generally to the attendees. Let me first of all acknowledge the wonderful and quite informative presentation that we just got. You know, there is this issue of lack of surveillance data, particularly for gender diverse populations. One question would be, there are so many surveillance that are done across different countries in the world. And I think particularly in Africa, there is this thing about lack of data on on the population, it's endemic, and one is wondering, what is the cause? Why do we have this gap, and how can we actually close this gap so that there is data available in the gender diverse population? Thank you.
That's a great question and comment. I wonder if Leanne, Cindra, or Brian want to weigh in on your thoughts on that.
Would love to. Leanne, do you want to talk to maybe in Southern and Eastern Africa?
Please go ahead, Sandra.
Okay, sure. So as we know that in many of our countries, trans people in particular are criminalized. So it's hard to do, if you're criminalizing a whole population, how on the other hand do you then, it's easy to say that they're criminalized, they don't exist, or we don't exist. And it's easy to say and have been said that, so basically they're rendering trans and gender nonconforming people as invisible. And this is intentional because they're criminalized populations. And that's why there's a big push on the national level to really get policies in place that recognize gender diversity. And therefore you could have policies in place such as HIV surveillance that standardizes gender diversity. But if you're criminalized from the get-go, from the very beginning, it's really hard to have policies that are rendering certain populations visible and providing services for them. So it really is it's all very political. But this is the research, and the HIV field is a really good sort of entryway to working on these more structural issues, to recognizing populations that are criminalized.
Yeah, thanks, Cindra. I just wanted to add as well that, and acknowledge that we as trans and gender diverse people are criminalized in the United States as well. So this is an issue globally. It's not just an issue limited to the global South. We are criminalized here in the United States, in the global North and in the West as well. And so there are a lot of options, though, of how researchers and we in the community, the HIV community, can address this data problem, specifically the data problem. I know sometimes it feels overwhelming to have to, take on the entire system of the criminalization and ongoing historical invisibilization of our community. But there are a lot of publications about how we can count transgender people using options such as the two-step method for data collection, which I can drop in the chat a little bit later. But there's lots of publications, lots of literature on how we should be counting in surveillance. We've done some of our work in the HIV research field to make sure that we're counted appropriately and recognized in the data. But we still have a lot of work to do. Even CDC in the United States still does not recognize in surveillance the existence of transgender people, broadly speaking. So a lot of work left to do, but the tools are there. We just need, as Cindra noted, the political will to implement and manifest these visions.
Thank you for saying that. I see we have a couple more questions. I just want to elevate something that's been coming up in the chat. The idea that IRBs could really be supportive and helpful as we think about trans inclusion in research. So thank you for that comment. Why don't we go to Reggie for your question or your comment?
Can I also respond very quickly, Jim?
Absolutely, Leanne, go ahead.
On the issue of, gender categories within Africa, it's very hard to collect gender on population or to collect data on any population that is not even recognized by our governments. And so this requires, as Sandra said, it will require political will, because I know in many countries, even though the CDC in-country officers have been talking to many African governments about the invisibilization of transgender people, citing that data is absolutely necessary and showing the extent of the problem, even in global North countries. it lacks the political will for our governments to be taking up these issues. Even though South Africa as a country seems progressive on the African continent, we continue to have these challenges, even within our context.
Thank you so much for adding that really important information, Leanne. Why don't we go to Reggie with your question or comment?
Okay, thank you all for the this dialogue is really, really important. My question is there any data for active duty military and military veterans that are trans living with HIV, either in the United States or beyond the United States?
Do any of our panelists have a thought about that? Or someone, go ahead.
I think within the African context, you know, putting military, living with HIV, being a veteran would be 3 levels of unpacking, you know, unpacking those 3 layers. It's unheard of in our context. I know many years ago, I had a colleague who was a trans guy and wanted to enroll in the military, but the space was really not enabling in terms of just having a trans body navigating their gender identity within a very masculinized patriarchal space. I think the South African military also has to be understood in the context of the South African apartheid regime. A lot of that militarized state kind of, you know, and information sharing would be very difficult to unpack, at least in the South African context.
Thank you, Leanne. And Cindra, Brian, would you want us or feel comfortable speaking to the US context or giving some thoughts on that? Or no?
I'll just say really quickly, it's a great question, Reggie. I don't know the answer to that question, but it makes me really curious how the VA, the Veterans Administration in the United States, handles this exact type of data collection that we've been talking about, the representation of transgender people. I'm very curious about that. So I'll be looking that up after the call. Thanks for the question.
And it also begs the question: does the VA actually fund gender affirming care or hormone therapy?
Well, I actually am a retired veteran and living with HIV. Actually have an organization called POS Vets, Military Vets. We have the largest VA hospital clinic in the United States, which is here in Decatur, Georgia / Atlanta. They do have the data. They do have programs for the trans population. The problem is that do not advertise. People don't know it's available. They don't connect with the community. And that's a very, very serious problem. We've had the Secretary of the VA here in Atlanta over the last couple of months. Our US Senator has had him. So these are issues that we're trying to bring up to them so that we can bridge that information and gather the data so it can be introduced to the general community.
Thanks so much, Reggie.
Yeah, thank you, Reggie. I think you've inspired some new lines of work for all of us to find some of this information out and tap into what you're talking about. I want to highlight a question from the chat, and then I see UK with your hands up, so we'll go with you, and then we'll go back. We have to see this preliminary data from the scorecard. So, but I want to make sure we get these questions from the chat and then from Kay. In the chat from Weimer, do folks know if Department of Health, I think DHS, Department of Health and Human Services, Department of Health departments, and folks doing biobehavioral surveillance surveys, are they including different identities from what we know? What can people speak to that question on whether departments of public health and various surveys are becoming more inclusive, or how much work do we have to do in that space?
I'll just speak really briefly locally here in Seattle is where I'm based, state of Washington, and King County, Seattle. Our health departments here do a fantastic job. So, to lighten the mood a little bit here, there's a light here where we do have a great health department here, both state and local, that collects gender representative data that is inclusive of transgender men, transgender women, gender non-binary people as well. And even, there's the national survey, the national NHBS, National HIV Behavioral Health Survey, that goes out and rotates through different communities over the years. And here, when we conduct that locally in Seattle and the state of Washington, we have the ability to adjust to make sure that the data that we're collecting here locally are representative of transgender populations. We also conduct a pride survey where we go around and make sure that this data is representative of behavioral health, social determinants of health here in the state of Washington, and we do a great job. So there are places around the world that are doing this right, and I think we should uplift and use these folks as a model to inspire others to do the same.
I just want to add, so the CDC has data, and a lot of the, for example, Gilead's partner study looked at the epidemiology, the HIV rates in trans and different gender populations, and that's where they base their enrollment targets based on the CDC data. So there are some national databases that the research could potentially be based on. And we'll
Thanks,
get more.
Cindra.
Sorry, go ahead.
No, thank you. Let's go to Kay. Want to come off mute and
Yeah, hi. I can't see myself, so hopefully I'm pointing the camera at me, not at the wall.
we see you great.
So I kind of wanted to circle back a little bit in terms of some of this data that you're talking about, and hoping that some of the panelists could expand on my answers. So there was kind of, in reference to the first question, there was acknowledgement of the issues of criminalization of trans people and lesbian and gay identities internationally, and then in the US there's criminalization of people with HIV, and I mean the MHS is just collecting the CDC is collecting that data through MHS without people's consent and in databases that are accessible to police even without a warrant. So it's interesting because it's like both there's an issue that there's no data, and then it also the collecting data and not have is also very scary because of the way it opens up people up to criminalization. So I was hoping if any of you, as you acknowledge that criminalization exists, if there's recommendations being made as to both getting people's consent for the collection of this data and then also protection of this data, so people aren't necessarily putting themselves in a vulnerable position.
Hey, thanks so much for bringing that up. I have a lot of thoughts on everything that you just said. I've written papers about what you've said, and actually, Jim, if you still have that link to the Lancet paper, this would be a great time to drop that in the chat. Molecular HIV surveillance, we could do a whole, day talking about the issues with MHS, molecular HIV surveillance, cluster detection and response. One thing I'll say about this connection that you're making between trans populations, data collection, molecular HIV surveillance, and criminalization is the paper that I think Jim is looking up. I wrote with a team of other trans and gender diverse authors in response to a paper that appeared in the Lancet the year prior. And this study that was conducted came to the conclusion that, and they used molecular HIV surveillance, which just to give a brief synopsis of that, for people living with HIV, when you go to the doctor, they take your blood sample to determine what strain of HIV you have to give you the appropriate course of medication. But they also share that genetic sequence of your HIV with the health department and with the CDC. And researchers go and access that data to kind of put together these family trees, looking at how HIV is moving throughout populations. And you can tell just from that description, there are a lot of ethical considerations with this practice. And one way that this has been used is to come to the conclusion, these researchers, cisgender researchers, came to the conclusion that transgender women partner, meaning have sex, with cisgender men. And this was like the big finding, that women and men sleep together. So this is an example of a research question that does not benefit transgender communities. We already know who our partners are, and we don't need researchers implementing risky methods and subjecting transgender populations to these risky research methods just to, you know, put out more in the academic literature to benefit researchers, but not to benefit transgender populations. So wanted to kind of give that example just to contextualize that there are research questions that are urgently needed within transgender populations. You know, everything we're going to talk about with the scorecard, all the different epidemiological studies, biomedical interventions, we need to know how these work in trans communities. These are urgently needed questions, but researchers often seem to be focused on the shiny new tools of MHS and CDR and phylogenetics and you know, the opportunities to publish this really interesting work, but that doesn't necessarily benefit our people. So I just wanted to make that connection.
Thank you for that, Brian. And I did drop in the chat your recent paper from last year, research on transgender people must benefit transgender people. So thank you for highlighting that. I think we'll hear from Eileen really quickly, and then we're going to move on to what we've learned from the scorecard. So go ahead, Eileen.
Hi, I work at the National Institutes of Health and the National Institute of Child Health and Human Development, and I've worked closely in the past with the Sex and Gender Minority Research Office in the Office of the Director at NIH, and I know that they recently put out a notice of special interest for researchers to actually include. I put the notice in the chat, but it's also, you know, to include people in different groups in studies that hadn't included them, to try and actually get more LGBTQ people into studies. And I just wanted to make sure, I'm sure you all know about the SGMRO, but just in case you didn't, some of you might not, the NIH does have a whole office in the Office of the Director that's working on this. And I know a few years ago, the clinical center at NIH is the big research hospital. And a few years ago, the SGMRO work to get in place when you first get, everybody who goes to that hospital is on a clinical trial, and everybody goes through an intern, you know, a check-in process. And now they always ask, what sex were you assigned at birth and what is your current gender? So everyone in the hospital gets asked that question. So everybody in a clinical trial at the NIH Clinical Center is asked that. So they are trying to do somewhat more inclusive things. I just wanted to mention that. Thanks.
No, thank you very much. Thank you for sharing that information. And there's always folks, we're all on different wavelengths and learning at different speeds. So I'm sure it's very appreciated by a lot of us, including, thank you, Brian, for spelling out SGMRO, which I couldn't have done as quickly. So I appreciate that. So thank you, Eileen. And I think we're going to turn it back over to the presenters to walk us through the scorecard. And, you know, we're going for another half hour or so. So we will definitely have more time to discuss and chat these findings and anything else that comes up for you as we discuss.
Thanks, Jim. Drum roll. Da, 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 da. Okay, so we've talked about the scorecard coming out of the manifesto. We use the visions in the manifesto to then score the last 30 years of efficacy trials in HIV. And we're going to assess them. The way we assess them is we reviewed their protocols, their post-study results publications, and we looked at the clinicaltrials.gov website. And now we are going to use this as a tool to keep on advocating for more and more trans inclusivity in the HIV field. And this actual tool that we're revealing today, the indicators and the results, we hope to pass it on to you as researchers and you as trans advocates to help also operationalize this tool. And a big shout out to Richard Jeffries, who we see is on this webinar today, for being one of our supporters and sort of guiding us in which studies were important. So thanks, Richard. And I think so these are the 41 studies, the key studies in the last, since 1991, so in the last 30 somewhat years, that are milestone trials in treatment, in vaccine and antibody and PrEP and microbicides that have gotten us this far biomedically. And so we've interrogated each and every one of these according to the manifesto about how well they included trans and gender diverse people. And we are going to share with you the results right now. So first, before we share the results, I'm going to tell you the specific indicators that we looked at. So we went to see, was there trans participation? What if there was trans participation, was it actually disaggregated? Was it inclusive of gender non-binary people? Was it inclusive of trans men and trans women? Were there actual trans and gender diverse systems, like data systems? For example, were there enrollment goals? Were there actual targets? How many, were there certain number or percentage of targets for people who are trans and gender diverse? Did they disaggregate the data from trans people? Was there a specific outreach and marketing to places where trans people and gender diverse people congregate? Were they recruited specifically in their own spaces? Did the staff of the research of the study and the researchers did they look the same? Did they represent the community, the trans community that they were reaching out to? Did they form authentic partnerships with the trans community and not just the tick box of a community advisory board? Long-lasting partnerships. And did they select competent research sites, meaning research sites that have proven experience with the trans community and that they're competent in their care? They could either provide or refer to gender affirming care. So these are what we rated all of these 41 studies on. Oh, sorry. And also, did they include gender affirming hormone therapy in the study? Not meaning, did they actually account for it? Did they look at the safety? Did they look at its interactions with the intervention? Did they look at its efficacy? And as Aileen had mentioned, the two-step reporting, when they asked for someone's sex or gender, did they implement the two-step, which is the gold standard of identifying someone? So someone is asked the two questions. They're asked their sex assigned at birth, and then they're asked their gender identity. How many of these 41 trials did that? And language, did they adhere to the best practices in their protocols and in their publication around talking about gender and gender diverse people? And there's a lot of references to proper language and protocols in the manifesto. So now I believe we're going to hand it over to Brian to talk about the results.
Yes, thank you so much. I also realize I've not introduced myself yet. I'm Brian Minalga. I'm gender non-binary. I use any pronouns. And big thanks to Cindra for inviting me to do this project, the scorecard, as well as the Manifesto Roadshow. I also just wanted to note that this is my first public appearance as Deputy Director of the Office of HIV/AIDS Network Coordination, based at the Fred Hutchinson Cancer Center in Seattle. So, I want to note that not only to let you know who I am, but also just to remark on the fact that it takes a lot to get trans and gender diverse people with the title director after our names. And so just wanted to thank, even those of us with as much privilege as I have. So I wanted to acknowledge that as well, but just want to thank everybody in my community who supported me in getting here. Wanted to shout out my office. I see some of you on the line, Pedro, Tasia, I'm sure Russell, Greg, and Tyler are around as well. From Hank and, Cindra, AVAC, all of you, we all really stand on the shoulders of trans and gender diverse people in this work, whether we acknowledge that or not. So let's acknowledge that now. All right, here we go. Preliminary scorecard results. What did we find from the analysis of these 41 studies? let's take a look at the timeline first and foremost. So we're working with studies from 1990 into the future we're looking at as well. And what you'll notice first is that for the first half of our analysis period, the earliest study we looked at actually started enrolling participants in 1991. So from 1990, let's say, through 2006, this first half of our analysis period, there was no transgender representation in any of these milestone studies. And again, I want to emphasize that when we're talking about milestone studies, these are studies that we looked over the course of the HIV epidemic, the HIV pandemic, and identified studies that made a meaningful impact in our knowledge of HIV, how we respond to HIV. So the first half of our analysis, there's no transgender representation, meaning we can't generalize the findings of those studies to transgender people, the clinical trials results from the studies that took place in the first half of our analysis. We did note that the word transgender first appeared in the year 2005 in a study protocol of the STEP trial, the STEP vaccine study. However, there were no transgender or gender diverse participants ever reported to have participated in that trial. So it's an important trial to note because the word transgender actually does appear in the protocol, the design of the study, but it was never reported that trans people participated in that study. The next year, actually in 2006, I think, is when IPREX first appears. Oh no, that's 2007 is when IPREX appears. And that's the first study that included trans and gender diverse participants. So out of our 41 studies that we looked at, these are the 12 that you see in these boxes on the slide. Only 12 out of the 41, which is about 29%, so less than a third of studies in our analysis included trans and gender diverse people. So one takeaway from this is that we only have had 17 years of inclusion of trans and gender diverse people in milestone HIV clinical trials. In the world of clinical trials, it's a very short period of time. And when we look at the time of inclusion from 2007 to the present, we also will see that in the early days of inclusion of trans people, this was not conducted perfectly or perfectly executed. So we're getting better over time as well. So when we talk about inclusion, there's also a spectrum of inclusion too. So let me walk you through this key and what these icons mean. So you have the names of the studies, IPREX, Partner 2, et cetera. And the key, these first three, you have the kind of like dark maroon image, the purple image, and the blue image. These show if the study included respectively gender non-binary people, transgender men, and or transgender women. So you can take a look at the studies that included those three distinct populations. And we're going to continue to emphasize that transgender people are not monolithic. And when we're asking research questions, we need to ask these questions of each population distinctly. The orange icon represents whether or not the study included gender-affirming hormone therapy as a research variable, as a research question, as Cindra was noting. Did they take it into account for eligibility of participation? Did they take it into account for safety, efficacy, how hormones interact with the study intervention, et cetera? So those are the studies that performed that analysis. And lastly, the green icon, this represents studies that not only included transgender people in the study design, meaning trans people were eligible to participate, but these studies with the green icon also explicitly marketed the study as being inclusive of transgender people. So only a few that we have here, HPTN 083, which was the injectable cabotegravir study, AMP2, one of the antibody-mediated prevention studies, Mosaico, which just announced yesterday some of its preliminary results on a webinar. And then we have these other two studies as well, industry-sponsored studies, Empower 24 and Purpose 2, which we'll talk a little bit about. So let's talk about, so those were the 12 studies, but let's talk about the actual number of trans and gender diverse people who were in these studies. So if you look first on the left, 99% of the participants in these 41 clinical trials were cisgender people. These trials were really largely designed for cisgender people. Less than 1%, we're only talking about 1,340 people, less than 1% of participants across these 41 studies from 1991 to the present were transgender people. And I should actually note as well that this doesn't include all 41 studies. We removed Mosaico, Empower 2, and Empower 24 and Purpose 2, because these studies have not completely released their results yet. Mosaico, as I noted just yesterday, released preliminary results on a webinar. So if we include the Mosaico results, the numbers shift just slightly, where cisgender people still represent 99% of participants in these trials, but trans and gender diverse representation goes up from 0.78% to 0.96%. So we're still below 1% for transgender representation, even if we adjust based on the estimates given yesterday during the HVTN's Mosaico webinar in conjunction with Janssen. If we just look at the slice, the little purple slice, the less than 1% of trans and gender diverse people in these 41 milestone studies, we can also see a disparity within transgender representation, whereby 94% of the less than 1% trans people are transgender women. So as Leanne really poignantly noted at the beginning of the webinar, when we say transgender, we often just mean transgender women. And it's really important that we start to change our mentality around that, because this is what happens when we stick with the status quo. We're going to end up counting transgender people, but really that just means transgender women. And these numbers are so small. I mean, for trans men and gender non-binary people, we're talking about numbers in the 30s, 37 trans men out of, I think the total number in these studies is about 178,000 people. And within the trans slice there, it represents, 3% for both trans men and non-binary folks. So this is a really big finding. These numbers will continue to change as additional studies do a better job of enrolling and intentionally including trans people. But this is the trend right now, and we need to manifest the vision of the manifesto in order to change this pattern. The other important thing to look at, and another way to think about this, is what I was saying about what we know about study products, study interventions, and how our response to HIV biomedically, how does this work for transgender people? So when we think about treatment, vaccine, antibody, and PrEP and microbicides, how many of these studies are including, by study type, transgender people? So in the treatment world, we looked at 11 studies. Only 2 of those studies included trans people. In the vaccine and antibody world, only 4 of the 11 studies included trans people. And when we look at PrEP and microbicide milestone studies, there were 19 studies total. Only 6 of those studies included trans and gender diverse people. And when you further disaggregate what we mean by transgender people, again, you'll see that the vast majority of these studies are including transgender women and continuing to leave behind transgender men and gender non-binary folks. Lastly, this is our last big data slide, and then I have an exciting quiz for you. So this is studies reporting gender. So we've been talking about the study design, who's included in studies, but once a study finishes and they report results in publications, large publications such as New England Journal of Medicine, The Lancet, when they report at big conferences such as CROI, how many of them actually reported the gender of the participants in those studies? So what we find is that the majority, of the 38 studies that have reported their study results, 28 out of the 38 did not report by gender. So, everything I just presented, we did this analysis, we did the digging to find who was actually included in the studies. But if you just look at the primary publications for these 38 studies, you'll find that the vast majority are not even including the gender of study participants, which is a problem because, a lot of these studies are publicly funded. And even those that are not publicly funded are still affecting our response to HIV. So what I will say is that 5 studies did completely report the gender identity and sex assigned at birth of participants in the trials. And actually it's 6, because you'll see the one in dark purple. I included that as a separate slice of the pie, because that one study was a study for cisgender women, and it was designed intentionally for cisgender women, rightly so. There was another study asking the same research question for trans people, but I include this as a separate note because we care about cisgender people too, and cisgender people also deserve to know who is represented in the study. You know, does the study apply to cis women? Does the study apply to cis men? Does it apply to gender non-binary people? These are things that we as the public and we as people working in HIV have a right to know. And so it's quite a shame that only one of these studies, you know, designed specifically for cisgender women, is actually reporting its results by gender. There were also 4 studies in our analysis that they did report their study results by gender, but they weren't complete. And we can get a little bit into that if we want to know. I want to get to discussion, but just one example, you know, included in that 4 is Mosaico. And that's just because they just released preliminary results yesterday. So we don't have the full breakdown. You know, they did report that I think it was about 8.7% of the total study population was transgender, but we don't know the breakdown. Is that trans women, you know, how many trans men, how many gender non-binary folks? So that's just one example of incomplete reporting that I very much trust in this case of Mosaico. We'll find out more about that as time goes on. So let's digest a little bit of that. And as we're digesting this, these data I've just shown you, sticking with this idea of reporting. So what do we mean by reporting in publications? I have a little quiz for you. So put into the chat your answer to the question, and I'm going to give you the information that you need to answer it here. So the question is, which study of these 3 scored the highest on how it reported its results, meaning it reported by gender identity, sex assigned at birth, so you can actually tell who is in the study. Your 3 options are A, pop art, also known as HPTN 071, B, partners prep, or C, uhambo, also known as HVTN 702. And the question is why. So on the following slides, I'll show you what actually appears in the primary publications of these 3 studies. So here is the baseline demographic characteristics of participants in pop art. So this is option A. Take this in. You know, notice that we have a characteristic of sex, male, female, we have age, we have marital status, and then we have the 3 groups of the study, group A, group B, and group C. So there's pop art, option A. Option B is partners prep. So here again, we have baseline characteristics. We have male sex, number in percent in the 3 groups. We have age, education, monthly income, sex with an outside partner, CD4 count, RNA, circumcision status, and in parentheses, you have men only, using contraception, women only. So start to take this in, see the patterns that we have here. And then your option B is HVTN 702. We have age group, body mass index, gender identity, and these are separated by these categories of women and men. So I'm going to check in the chat here, and I'll put up again your options here. You can put option A, B, or C, and if you have a note as to why. Okay, I see some B's here. Okay, thanks, Jim, for the Mosaico news. Partners because it used the 2-step. Richard says C. Okay, I've got another answer for C. Asked about gender identity, not just sex. Very good. C sounds more inclusive. C because it included gender identity. C's data looked most complete to me. I tend to agree with the C's. That's my answer. I would say C as well. And the reason being, the one note that I would make is we have these characteristics of women and men. To me, those are ambiguous terms. I would perhaps use the characteristic of sex assigned at birth, male, female, And then, on this y-axis here, gender identity, I love how this study in particular includes transgender men and women. Again, I would say that, I would change that, as well as gender variant, which, there's a lot of different terms we can use for that as well. When we think about B, partners prep, limiting circumcision status to men only, to me, that implies that we're not even considering other people who may have a positive circumcision status to be anything but men, that we're only considering men to be those able to become circumcised. And the same for women using contraception. Women are not the only people who use contraception. So that would be my feedback for partners prep. And also note that they only have male sex on here. That always bothers me a little bit when we just have male sex reporting, and then you have to do the math to subtract, well, how many people of female sex were included in the trial. That should just be reported, in my opinion. And here as well, this is pop art, not so bad. We're just reporting results by sex, but again, that's an ambiguous term. Is that self-reported? Could that be a conflation with gender? Are we actually talking about, men and women, which could then be disaggregated further into transgender, cisgender? What does that term sex actually mean? So this is why we prefer the term sex assigned at birth. It's much more specific, much more precise. So just wanted to do that quick there. Y'all did great. And just to kind of wrap up here, I know we're running short on time. So a couple conclusions. Since 1991, trans and gender diverse people made up less than 1% of participants in 41 key HIV clinical trials, and the vast majority were transgender women. Trans men and gender non-binary accounted for only 3% of the already underrepresented transgender people, respectively. The first reported transgender enrollment was not until 2007, which is way too recent, but we applaud the IPREX trial for getting us started with trans enrollment. In total, 29% of the 41 trials analyzed included any transgender and gender diverse participants. Only 3 trials explicitly justified transgender exclusion. So that's another thing we look at. If you're not including transgender people, are you explaining why in the design of the study? And that's something that we should all hold researchers accountable for, is if there's no transgender inclusion in a trial, there should be some explanation as to why. So if we take something away, let's all do that. Ask that question. Are you explaining why trans people are not included? Here's where we get into some of our systems and processes to support the inclusion of trans people. Enrollment goals is one opportunity that researchers have to set a goal for the number or percentage of trans people to enroll in a particular trial. Only 4 trials in our analysis did this. Those are HPTN 083, which set an enrollment goal for 10% transgender women. Purpose 2 had an enrollment goal of 20%. Empower 24 set a number of 100 transgender people to enroll. And we just learned yesterday that Mosaico set an enrollment goal of 10% transgender enrollment. This is my last slide here, conclusions, and I'll pass it over to Cindra. So only 5 studies included trans people in outreach, marketing, and recruitment strategies. You can see those 5 here. Only 8 studies accounted for gender-affirming hormone therapy as a study variable, which, as you know, is one of our indicators from the Transgender Manifesto. Another 8 studies clearly and correctly defined the study population in terms of gender and sex. That's a nice way of saying that the rest of the studies did not clearly and correctly define the study population in terms of gender and sex, but the ones that did it right are listed here. Only 6 studies clearly and correctly reported the gender and sex of participants in primary publications of study results. I didn't say this before, but I wanted to note that 3 studies had a second publication that only focused on transgender people, and those studies did report the gender and sex of participants. What I want to say quickly about that is we shouldn't have to look up a separate study on transgender people. We should be able to see the gender and sex of all participants right up front in the primary publication of study results. And lastly, transgender and gender diverse involvement, which means partnering with transgender organizations, hiring transgender staff, and selecting sites that represent transgender communities and have a good relationship with transgender people, there was not a lot of information available on the utilization of this process of trans and gender diverse involvement. But one study satisfied all categories, and that's a study that is still ongoing, Gilead's Purpose 2 study. Thank you so much. I'm going to pass it back over to Cindra to wrap this up.
Thanks so much, Brian. Just really generally, I want to emphasize that all of those results that Brian just listed, that those studies that hit that did the right things, that most of them are current, ongoing, or recent trials. So there has been a big, I don't know if I would say a sea change, but there is a trend, a definite trend that we have noted that trials are indeed becoming more inclusive. And we want to use this momentum and keep it and ride this wave and keep going. And so here are just some broad strokes and that we are going to continue to advocate for, and we hope that you'll join us. I don't know if I need to read them all out because we're getting towards the end, but so some of them are a repeat, like that advocates and researchers we really need to make sure that the research site employs trans and gender diverse people and that trials are designed before even funding comes in with trans and gender diverse people on the staff, that there's equitable funding for the TGD community that is actually involved in the trials. And then really importantly, that a lot of the clinics, the trans run clinics or the clinics that serve trans people, a lot of them are really understaffed and tapped out, and then they are also tapped to do research. So they need to be really supported, and it needs to be additive. Any research that if they're selected as a site, it needs to be sustainable and integrate the research into what they're actually doing. Same with demonstration studies. If there's a demonstration or implementation study in with trans people, that it doesn't just end and then services disappear, that it really needs to be sustainable. And I'm going to really skip here and just say that trans, masculine, and gender non-binary people, as you saw from the data, are completely almost completely excluded from the research. And this really needs to change. We need to understand the risks, the sexual partners, and the activities. One recent study showed that trans, masculine, gay men, so trans men who are MSM, their rates of their prevalence was 11%. So this is something that has been a big gap that really needs more attention going forward. We talked about standardizing HIV surveillance data, and we talked a little bit about really from all of these beautiful countries that are on the webinar today, we really need to do the national level advocacy for the acceptance, the decriminalization, and the embracing of gender diversity. And I think that we end there with the slides, or maybe there's one or two more. The great J.D. Davids, I'll read his slide. Trans people don't stand in the way of epidemic control. We are a solution. If you want to join us, if you want to invite us to do a roadshow and talk to your people, talk to your researchers, please get in touch with us at tgagenda@avac.org. Next slide. And now we can open it up for discussion and more questions.
Thank you. What a great panel, all of you, Leanne, Cindra, and Brian. Really beautiful work. Thank you for letting us see each other. And if folks want to come on screen, we can go a little bit later if the conversation continues. I hope it does. I want to take my prerogative now and ask a question, Brian, and this is for all of you. But Brian, you mentioned that if trans people aren't going to be included, that there needs to be a rationale provided. When I hear that trans people aren't going to be included, my first instinct is, what a bunch of BS, right? I feel like you just don't want to do the work. It's too complicated. We're not sure, how trans people have sex. So some trans people might get pregnant. So we don't know what's going on with that. And I just find it to be a litany of excuses for doing important work for people who matter. But are there, so that's my kind of, where my gut is, but are there like legitimate reasons why trans folks wouldn't be included in a study? And what would that rationale be?
Great question. And my answer is yes. And that may surprise you that yes, there are legitimate reasons trans people may be excluded from a trial. Let me give you a specific example of the AMP studies. So we have them listed here as AMP 1 and 2. So these studies occurred concurrently. They were designed together as, we'll call them sibling studies. The first AMP study was designed specifically to answer this research question of antibody-mediated prevention. Can we prevent HIV acquisition using an antibody in cisgender women in this geographical area? AMP 2 was designed concurrently with AMP 1 to ask that same question: can we prevent HIV acquisition in transgender people and cisgender men using this antibody in this geographical location? So I think that's a legitimate reason. If you are also conducting a concurrent study that does include trans people, but you need a separate study to answer the question in a cisgender population. I'll also give the example of which one was it? It was the Opposites Attract study. This was one of the studies that led up to the U=U advocacy tool that we now have. It was a study of partners, where one partner was living with HIV, the other partner was not. This study was conducted exclusively for gay men. Now, this is a population that is overrepresented in the HIV epidemic as well. And this study, as well as Partner 2, actually was the study that included transgender men in its definition of gay men. So I want to highlight that as well, that sometimes it's important to conduct a population-specific study to answer a research question. And what I would be remiss if I didn't mention the studies that are now being designed exclusively for transgender people. So these are studies that exclude cisgender people to address a research gap for transgender populations. So that's a really easy way to look at why you might exclude a population to answer a research question in an already underrepresented group.
Thank you for saying that and walking me a little bit off of my histrionic ledge. I'm getting very angry. A lot of my reaction, I love the work you've all done, but this less than 1%, the invisibilizing of people. I myself, as I'm not a trans person, but trying to be an ally, I don't know how many times I've heard people say, well, the numbers are so small, like we just don't really, there's not that many people. It's like, what if there was just 5? Like those 5 people matter, right? And if it's 5 people who have an incidence level that's much higher than the general population, how dare you have that? How dare you say that? And how dare you just throw your hands up and say, well, it's too small or it's too complicated? But I appreciate having some more context. I'm still mad. And I guess that would be my next question. And then I would like to encourage other people to raise their hand. But as someone who is not a trans individual, and I'm, a cis white man loaded up with privilege, what is something that I can do to be a better ally in this effort? What can I do to show up and be a louder voice for trans people of all genders?
So I think in the South African context, and there's been a lot of invisibilization of trans people due to not wanting to address the complexities of trans people. And that's another thing that's becoming exhausting. It's like, the issue is too complex. Oh, y'all don't know what you want. And so I think for me, when an ally speaks for me, let us speak from the same knowledge. Let us work from the same space. And that would look very differently for you, who is a white person from the US, and I'm just assuming here. I don't want to assume anything about your race, but just as a person living in the global north, I think you might have a different voice than me as a trans woman of color from the South. And I think a lot of what we've managed to accomplish in the HIV response to trans people in South Africa has been to use the voice of our allies. When and I just typed that in one of the initial meetings at the beginning of addressing HIV and the trans community in South Africa, one of the responses that USAID PEPFAR gave us was like, the community is so small. How do we really, capture the experience of 1 or 2 or 3 people? And it's never for me about that, because the issue of a community being small is relative. And like I said in my presentation, that not everybody uses the Western term of transgender. We have a lot of ethnic descriptions of gender diversity in the South. And so when funders and policymakers say that this is a small community, to challenge them to think far more broadly than just the Western term trans and transgender, because in the South African context, many people sometimes are uncomfortable, even within meetings and workshops, to use the term transgender, because what does that mean? Like, does it mean somebody who's had access to service? Does it mean a social transition? Does it mean a legal transition? What exactly does that mean in the South African context? So for me, really, I think I want to pay homage also to cisgender people who spoke, and people who had meetings and lobbied donors to think about the complexity of trans, and not to shift us all off to some space where that makes it comfortable for policies and governments, policymakers and governments, to not think about the complexities of being trans.
Thank you, Leanne. Such wonderful words of wisdom, and I'm so honored that you're here today, and so honored that you're in so delighted you're in this world doing this work. You're amazing. So thank you. Do we have other questions or comments? People want to raise their hand. We are a few minutes over, but I'm happy to keep it going if you all want that. Otherwise, I will ask for each of our glorious speakers to give some final words of wisdom. And I would love, in those final words, action steps, something that each of us can do from whatever spot we sit in, from whatever room we're in, whatever chair we've got, whatever identity we have. What can each of us do to improve trans inclusion, non-binary inclusion? So while you're thinking of that, Ernest has saved the day, let you have some moments to think that through, and Ernest will let you have like one of the last questions or comments here.
Yes. Before you close it, Jim, just one very question based on the conclusions from the last presenter. One of the things that is recommended is engaging trans gender diverse people beyond cabs. I'm not sure I really understand that. If perhaps you could just shed a little bit of light on that, so that we go away with certainty, especially for us who work with commission advisory boards, to know exactly how do you do that? Thank you.
Thank you, Ernest.
I'm happy to take that for just a quick second. Thanks, Ernest. Important question.
Ahead.
So good participatory practices. This is when a research site really really integrates into the community that it's there to serve and work with. And so it's not just about having CAB meetings once every, I don't know, month or however, but it's really working with the, for example, is there a trans-led organization in that region, and building over time relationships with this trans organization or this LGBTQ organization and the trans people that live there, and having buy-in and having them be as invested in the outcome of the studies as the actual researchers are. So it's really about developing relationships over time and authentic relationships. So I hope that sort of gives you a little bit of a vision of what we're talking about.
Thanks, Cindra. So how about we go with our wrap-up comments with strong takeaway action steps. I'm not going to choose who goes first. The three of you can fight that out, and we'll see where the chips fall.
I'm happy to go first.
Great.
Thank you. I want to reiterate my thanks to colleagues who joined here tonight. Cindra and Jim and Brian, Albert also, for putting together this fantastic panel. I think really my takeaway message would be, as a trans person and as a longtime HIV advocate, that one, the trans community is no longer willing to shrink itself to fit a colonized global agenda. If you want to invest in the response, do so with the intention of not further colonizing us. We know what we need as a community who are both trans, who are African, who are based in a developing context. We know what that picture looks like on a day-to-day basis. We have lived through many of these things. Cindra may tell you that I always share the story that when funders asked us, how do you know there's a problem among transgender people and HIV? And I always respond to them and I said, because we were the ones who are giving the palliative care to our sisters when they are at the end stage of AIDS disease. We are the ones who organized the funerals. We were the ones who packed up their living accommodations when they passed. And that is how we know. And that also further ties into what counts as research. Those stories often, are taken only as anecdotes, and somebody might quote them in some report somewhere, but that is the realness of this epidemic. And just because that hasn't been captured by some scientific methodology, it doesn't make it any less real, authentic. The community knows exactly what it wants and needs, and we are championing exactly for that. No data, no more. We have data, whether those be pockets of data that exist somewhere, whether those be extrapolated from MSM samples or sex work samples. We can no longer use the excuse of no data anymore. We have ventured past that. That's the one point I want to make. The other point is that trans people live intersectional lives. We are trans people. We are people living with HIV. We are scientists. We are advocates. And it's very condescending that when researchers come from the West and North, that we are placed within a particular identity, and that of people who sit on advisory committees and people who are data collectors. I'm no longer prepared to do data collection for anybody without seeing the accountability to the community and without ensuring that my voice, both as an activist, as a scientist, and as a transgender person, is fairly and adequately represented. Thank you very much, colleagues.
Wow. You have set a high bar for these final words of wisdom from our last two speakers. Good luck, Brian and Cindra.
Ladies first. Go ahead, Brian.
Thank you. So this is maybe an interpretation of the question. I've been talking about the data for years, how to collect trans-inclusive data. I've been talking about the research. Like, I feel like we're done. I'm done kind of talking about those things. What I want to call out or call in perhaps, and it's a call to the whole field of HIV, is to take care of each other, lift each other up, support each other. Sometimes, ego comes into play in this field. Sometimes, there's, territorialism. And I say this because I'm thinking about how much all of us have going on. A lot of trans people are struggling. A lot of cis people are struggling. This world is too much to be, at each other's throats about, this, you're doing this wrong, you're doing this right. And I think a lot of times there's sensitivity around these things when we talk about trans and gender diverse people. So that's just something that's on my mind that I think is something we can all do very actionably. That doesn't have to feel so overwhelming. We have to change the whole data system. We have to change the way the NIH does work. We have to change the way CDC surveils people. We can change ourselves. We can just start with ourselves and change the way that we treat each other. We can be nice to each other. Get consent to give a trans person a hug and then give them a hug. And let's just, and I think if we fill each other's cups in that way, that's a lot of the battle. It'll be easier to change the data systems and to change the surveillance systems if we're treating each other not only humanely, because that's how you treat animals, but let's treat each other humanly. Let's be kind to each other. And that's really, really all I want to end us with on this webinar today is let's be together in this.
Okay, well, speaking of kindness, I mean, I couldn't have asked for a better team than Leigh-Ann and Brian because they were so kind and brought me all the way. So thank you both. Thank you. But I do want to bring up one annoying fact is that most of the research that is done with or for transgender people, the funding goes to cisgender people. And I feel like that's where a lot of, I think, the advocacy or my advocacy needs to be to highlight that. To really get the funding to the trans researchers, but also the trans communities who are really struggling with all of this intersectional layers of barriers. So, and with that, I can commit myself and AVAC to keep supporting you all and being on the front lines and doing what we all need to do to have a trans-centered response to the HIV epidemic.
Beautiful. And the three of you, the different aspects that you brought up and the different takes you gave were just perfect. Totally unplanned and so right on. Things we can do that are very intimate and personal, and to Brian's point, and then some of these much bigger issues to Leigh-Ann and Cindra's point and everything in between. But I will end by just really emphasizing the trans-centered and trans-led, that it is high time that we all support that and make that a reality. I worry so much for my trans family here in the United States. I'll speak specifically. Such terrible things are happening in the political universe here that have real world consequences. So many people's lives are at stake. And it's gotten so bad that even, providers of healthcare to young queer kids, to young trans kids, to young non-binary people, they're being threatened with their lives. I'm here in Chicago, and we have a center here that does wonderful work with transgender, non-binary adolescents and young people. And a lot of their providers have to have basically security details, and they get death threats every day. And that's the providers. So that you can imagine the actual people living with this. What does that feel like? How is that? It's heartbreaking. And so I think Brian's point, we can all change the script in our own worlds by loving each other and showing that love and pushing back on all this hate and idiocy. I really thank you all for this really beautiful webinar. what a great way to kick off 2023 with the choice agenda. I hope folks come to the CROI webinar. It sounds like there's interest in the decolonization one. Hope you'll come for that. In March, we're going to have something on MPOX and just lots and lots of other stuff. So many webinars I can barely count. But look forward to see you there, hopefully on the choice agenda listserv. And look for an email. We'll be following up with all of these wonderful materials, recording slides, a resource document from all the great things that were shared in the chat today. And otherwise, with that said, thank you. Thank you for hanging out. Over 40 people stayed with us, 15, 20 minutes past the hour. So love you for that. Have a wonderful day, afternoon, evening, and tomorrow. See you soon.
Thanks, Jim. Thank you so much. Bye all. Thank you.
Bye, take care.